Thank you very much. You've mentioned it a few times, Maria. No one's going to kill you, don't worry. So we're going to talk about the poorly responsive patient. And in fact, in our celiac center at Columbia University in New York, this is the most frequent patient we see. The one that comes along and says, I have celiac disease and I still feel unwell. Now, the management of celiac disease is a gluten-free diet, and that can be very difficult. Patient support groups provide different information. Experience of dietitians varies. People go to the internet, and there are a lot of pitfalls, especially eating out in restaurants, prepared foods, fast foods. Communion wafers are not exempt. And medications may actually have gluten in them, because when you take a pill, the bulk of the pill is a filler, and typically it's cornstarch, but it may be wheat starch. There is a lack of knowledgeable dietitians. There are really just a handful in the United States, and a study has shown this in the United Kingdom. We actually did a survey, and we're interested in how many people saw dietitians and what the effect was. And in fact, people with celiac disease, 20% never saw a dietitian, and 40% saw a dietitian once. 40% saw on multiple occasions. And interestingly, amongst these 400 patients, we couldn't really determine any benefit in whether they saw a dietitian or not. I'll come back to that in another talk. Now, what about non-responsive celiac disease? Now, most patients do respond to the diet, but there are estimates of 7 to 30% that don't respond. And as I mentioned, we're seeing increasing numbers like this. So the first question that we've got to ask is this really celiac disease? Because it's difficult to improve when you're on the wrong therapy for whatever you have. So did the patient have a biopsy? And if the patient really didn't have a biopsy, we can't be sure of the diagnosis. All adults need to have a biopsy as a baseline, as well as to establish the diagnosis. There are pediatric guidelines in Europe that suggest that a biopsy is not necessary if the child has symptoms, has a tissue transglutaminase antibody more than 10 times normal, and then on another blood sample, which is important because you can have temporary gluten autoimmunity, have a positive endomysial antibody and the appropriate genetic makeup, that you can forego the biopsy. Now, that has not been accepted in the United States as yet. If the patient had antibody tests, what antibody test? You can get, it's a very good, the TTG IgA is a very good test in a high-risk population, has a positive predictive value of about 90%. But in the general population, the positive predictive value is less than 30%. There's lack of standardization of tests. You can, the labs use different kits, and you can have a positive TTG antibody at one lab, and on the same blood sample have a negative one at a different lab. Some labs measure TTG IgG, of which we know no information except when the patient has IgA deficiency. The old anti-gliadin antibodies are thought to not have any role. We're seeing increasing numbers of patients who go to complementary medicine doctors and send off saliva tests or stool tests for antibodies to TTG or gliadin, and then get told that they have celiac disease. When questions arise about the diagnosis, does the patient have the appropriate genetic makeup to have celiac disease? Because if they don't, we think you can't have celiac disease. Now, what if a biopsy has been performed? So there are two different settings here. One is if the patient has villus atrophy but had negative antibodies. That's the topic of another talk I'm giving here. And then we have the celiac patient that had a biopsy, but no response to the gluten-free diet. Does that patient have refractory celiac disease? And it's important that, going back to my last talk, when we see someone and they bring the biopsy in or the biopsy report, we'll look at it and just see the number of biopsies taken. And if it's one piece or two pieces, we know that the disease may or may not be actually be made, just based on that, which we talked about in our last talk. Now, what about this seronegative villus atrophy? There are a whole host of causes. Certainly about 15% of celiacs can have negative antibodies. We have autoimmune enteropathy. We have drug-induced enteropathy, tropical sprue. We see tropical sprue in the tropical Isle of Manhattan. I'm sure that it's seen here. We're seeing less of it. When I first went to Colombia, it was a Puerto Rican area up in Washington Heights. Now it's a Dominican Republic area. And they both had tropical sprue, and interestingly, one had B12 deficiency and the other had folate deficiency along with their tropical sprue. Collagenous sprue, and of course, there are these other conditions. And then we were made aware only recently of this severe enteropathy caused by olmesartan that is available in this country. And I'll talk about that a bit later on today. So what are the causes of a poor response to a gluten-free diet? Well, it can be the wrong diagnosis. Most commonly, it's ongoing gluten ingestion. The conditions that we diagnose most frequently are lactose intolerance, fructose intolerance, pancreatic insufficiency, microscopic colitis, and bacterial overgrowth. However, all these conditions exist and may be contributing to the patient's persistent symptoms. So one needs to have a checklist or a systematic approach to these patients. We have to know that it's celiac disease. If it is celiac disease, we'll go in one direction, with the dietitian being very prominent. If it's not celiac disease, we go in a different direction. If the biopsy has healed, but the patient still has symptoms, then we know what to do to cause those, to evaluate those symptoms. And then finally, we've got to determine if the patient has true refractory celiac disease that may have a very bad prognosis. So one needs to have a systematic approach to these patients. Now, gluten ingestion is common. In all the series, the patients keep eating gluten. It may be intentional or unintentional. I have one patient who says that he gets terribly sick when he adopts a gluten-free diet. Totally unexplainable. If a patient at the end of, say, 2 years still have positive antibodies, they're not on a gluten-free diet. Gluten ingestion, even if we know that the antibodies aren't very sensitive to minor gluten ingestion, so intermittent gluten ingestion won't elevate the antibodies in a patient. But so if they're positive at 2 years, the patient's eating gluten. So say, I'm on a gluten-free diet, say your antibodies are positive, you're not on a gluten-free diet. Occasionally, we see low levels of persistent positive tissue transglutaminase antibody, and the patient gets beaten up, gets repeat endoscopies, and the biopsy looks fine. But that's usually low level, and it's frequently associated with other autoimmune conditions, such as type 1 diabetes. And in the best assessment of whether a patient is on a gluten-free diet is not negative serologies, but seeing an expert dietitian. And it's very important that if you're seeing patients with celiac disease, that your credibility rests on the quality of your dietitian. And I always tell patients that if their physician refers them to a dietitian that doesn't appear to know that much about it, they need to go back to the doctor and say that was not a good referral. Because we really don't know what the quality of our colleagues are in dealing with their patients or the dietitians that we refer people to. We're using more and more of these breath tests to look for lactose and fructose intolerance. Fructose intolerance is becoming increasingly common. High fructose corn syrup is being added to most prepared foods now. And some people are very sensitive to high fructose corn syrup, causing IBS-type symptoms. So we'll look for lactose intolerance, fructose intolerance, and on occasion sucrose intolerance. Small intestinal bacterial overgrowth occurs in these patients as it does in IBD patients. You know, the studies that have looked at IBD, celiac disease, and normal controls, the highest rate of bacterial overgrowth is actually in IBD patients. But interestingly, most IBD docs don't go looking for this. It's actually a valuable source of getting more information about patients. We did a study in which we gave patients Xifaxan and did breath tests and found that just giving Xifaxan to these symptomatic patients was not of value. So it's important to my mind to exclude bacterial overgrowth with an appropriate test before one embarks on a course of further antibiotics. Stool tests, ovarian parasites, giardia, and we're increasingly using this fecal pancreatic elastase because in patients with celiac disease, there's a relative pancreatic insufficiency. It's considered to be due to lack of the hormones coming out of the gut when a patient eats and the pancreas not being stimulated. In this study, once again from Sheffield in the UK, 30% of patients that were seen that had a poor response to the diet had evidence of pancreatic insufficiency. If you don't have the test, then it's probably worthwhile giving pancreatic supplements. For a period of time, I was the second largest prescriber of pancreatic supplements in New York, secondly only to the surgeon at Memorial Hospital who was doing pancreatectomies. But now with the fecal elastase test, we're using it more selectively. But it is something that's important to remember. Colonoscopy is important in the evaluation of these patients because not only the presence of microscopic colitis, but inflammatory bowel disease occurs in an increased way in people with celiac disease. It actually occurs more frequently in other family members of people with celiac disease as well. And in a study that we did, the age and gender adjusted prevalence rate ratio for both UC and Crohn's disease was increased. For a while, I thought that was probably just for being in New York, where we appear to have a lot of IBD, but it's been confirmed in other studies, especially in the United Kingdom. So the patient may not have one disease, they may have two diseases. And of course, we're very much aware that patients with celiac disease get microscopic colitis. It was about 4% of patients in our database when the database was about 1,000 patients. And it is associated with more severe villous atrophy. In most of the cases, the microscopic colitis is diagnosed in the assessment of a poor response to the diet. So it's after the diagnosis of celiac disease. Sometimes microscopic colitis is diagnosed at the same time, and that's very difficult to label those patients. That's the patient that gets both an endoscopy and a colonoscopy at the same time, and you come back with celiac disease and microscopic colitis. There is an overflow phenomenon. Microscopic colitis is just part of the pathology of celiac disease with the prominent intraepithelial lymphocytosis. So you can see people with severe celiac disease that just appear to have almost an overflow intraepithelial lymphocytosis in the colon. So it's difficult to label those people with microscopic colitis. And occasionally, in 10% of our cases, the microscopic colitis was an initial diagnosis, and with that diagnosis, people are then screened, do they have celiac disease? Now, refractory celiac disease is a very important concept because it involves several different parameters. So you need to have persistent symptoms. 30 to 40% of patients with celiac disease don't resolve their villus atrophy. They have persistent villus atrophy despite being on a gluten-free diet. We don't label those people with refractory celiac disease because they've got to have symptoms and villus atrophy despite being on the diet for at least 6 to 12 months. And it is not that common. It's primary when the patients never respond to the diet, and secondary when the patients relapse. It's not uncommon that patients are on a gluten-free diet for, say, 10 years, they're feeling great, they decide to go off the diet, they then lose their responsiveness to the diet. The major classification is based upon studying the intraepithelial lymphocytes. Type 1 refractory celiac disease have normal IELs. That is, that the IELs that are seen in the top panel here are normal. They express surface markers CD3 and CD8. So this is type 1 refractory celiac disease that you can't tell by these studies from a normal celiac. So there's always the potential that this type 1 patient is just getting gluten somehow. Type 2 has an aberrant intraepithelial cell, an aberrant IEL phenotype. They don't express any of the normal surface markers. No CD3 on the surface, but it is on the inside of the cell, so it will stain by immunohistochemistry. But the other normal T-cell markers, CD8, for example, is not present, and it's associated with gamma TCR gene rearrangement. So using immunohistochemistry, this patient has refractory celiac disease type 2 because all these IELs here express CD3 on the inside, so you'll see that on flow cytometry, but they don't express IEL surface markers of CD8 at all. And what's important to characterize these patients is the extremely poor prognosis of patients with type 2 refractory celiac disease, because these aberrant IELs have actually been described as being a cryptic T-cell lymphoma. And there's a very high rate of progression to the dreaded enteropathy-associated T-cell lymphoma that has a very poor response to any therapy. The 5-year survival of patients with type 2 refractory celiac disease is less than 50%. How are these patients treated? Nutritional support, of course, is important. Steroids are the mainstay of therapy of refractory celiac disease. And we use a lot of budesonide. Patients will take it 3 times a day, and we instruct them to open the capsule and take the capsule contents with like yogurt or apple sauce to get it delivered to the duodenum. So budesonide is the mainstay of therapy. And if the patients are sicker, it's an escalation of therapy using steroids. We'll use immunomodulators, especially in type 1 refractory celiac disease. There's worry about using them in type 2, whether it's pushing people towards lymphoma. Stem cell transplants have been used for people with type 2 refractory disease. Don't kill me, Maria, I'm going to go over. But we're just going to have a break, right? But there's no time for a break. Oh, I'm sorry. But no matter what the therapy is, the therapy of type 2 refractory celiac disease is very poor. And despite stem cell transplant, it's very hard to get rid of these clonal T cells. And many of the therapies will make the patients better for a short period of time, but the bulk of the patients that we've seen with type 2 refractory celiac disease have died, either from just progressive malnutrition or, interestingly, progressive neurological issues or the development of enteropathy-associated T-cell lymphoma. But they are a small fraction of the patients, and they're mainly being seen in the celiac centers. So just to go over it, here are a couple of series of poorly responsive patients. Gluten exposure. I too, Maria, find it difficult to diagnose IBS in patients that have a chronic intestinal immune-based inflammatory disorder. Microscopic colitis, refractory sprue, sucrose, fructose, lactose deficiency, eating disorders, small bowel bacterial overgrowth. Another, the last one was from the United States. This is a series from the UK. Once again, it's the same list of causes. Ongoing gluten ingestion, microscopic colitis, bacterial overgrowth, etc. Inflammatory bowel disease, refractory disease, and last but certainly not least, incorrect diagnosis of celiac disease. So non-responsive celiac disease is common. The patients need a systematic evaluation. You need to know that it's actually celiac disease you're dealing with. If they've healed their biopsy, you go evaluating them in one direction. If it's not healed, you go in another direction, looking to exclude refractory celiac disease. And this seronegative villus atrophy, which is the topic of another talk, is an interesting condition. So thanks very much.